Okay, we're going to start into lecture 14, which is our second of our digestive system lectures. Lecture 13 dealt with the sort of general features of the GI tract and some of the accessory organs. Remember, the GI tract is basically a very long muscular tube from mouth to anus that has four different tunics, which we looked at, or layers, with the mucosa, submucosa, the musculus externa, and the serosa. What we're going to do now is go through the different regions of the GI tract and go into a little bit more detail. So the first thing is looking at the oral cavity. As we look at the oral cavity, we want to look at the boundaries of that oral cavity. So starting off, we have the roof of the mouth. And when you think about the roof of the mouth, if you remember back to looking at our osteology section where we were talking about the bones, this is looking at a figure or a photo of the roof of the mouth. You can see here, of course, the dentition or teeth. We have the two maxillary bones that make up what we call the hard palate in conjunction with the two palatine bones. So if you take your tongue and kind of put it right at the front of your roof of your mouth and kind of run it backwards, or take your finger and do that, you'll notice that it's very hard, and that portion is what we call the hard palate. Of course, it's going to be covered with a mucous membrane, which you see in this photo right here. The hard palate is this bony structure we can see here. Right here is about the edge of that hard palate. And then behind the hard palate, we can see that the mucous membrane will continue as what we call the soft palate. So this is sort of that fleshy posterior extension of the hard palate or roof of the mouth. Um, the hard palate is functioning to separate the oral cavity from the nasal cavity. And so in these two drawings here, we can see nicely the hard palate. So this is going to be the maxillary bone, right, with the palatine process. And this is the little palatine bone right there, making up the hard palate. And then we can see this nice fleshy extension that continues. This is referred to as the soft palate that will extend to this structure back here, which we'll name in just a second. That's the uvula. So you can see just below the hard and soft palate, we have the oral cavity, which is this large space right here. And then above it, you can see the very large nasal cavity. So this is a little bit better view of that. You can see the very large nasal cavity. And then you can see underneath that hard palate is the oral cavity. Okay. All right. The floor of the mouth is really skeletal muscle forming the tongue. Of course, we have the dentition in the lower portion of the mouth. We'll also have some salivary glands that enter into the oral cavity here. But the majority of the floor of the mouth essentially is going to be the tongue. Okay, so we'll look in more detail about what features we have with the tongue. What essentially determines the end of the oral cavity and beginning of what we call the throat or pharynx will actually be marked by these folds of mucous membrane. There's actually two of them. We call them the arches, and you can see there's a front arch here, and then there's a back arch here, kind of coming off where this uvula, which we'll look at in just a second, sits in the center of the posterior aspect of the oral cavity. So again, we have a posterior arch and an anterior arch. And these are named according to the fact that they're coming off of the soft palate. So we'll call them plateau because they're coming off of the palate. So plateau, and we move forward to the tongue. The tongue is called the glossus. So this front fold here is called the platoglossal arch. And then this back fold here is called the platopharyngeal arch. So you have a front fold again, which is the platoglossal arch because it comes in and touches essentially the mucous membrane of the tongue. And then we have a posterior fold back here that we call the platopharyngeal arch. And it's called platopharyngeal because it's coming from the soft palate, but it's actually right at the junction between what we call essentially the throat, which we can see back here, or the pharynx. That's going to be our next region. Sitting between these two arches, they kind of form a gap here, is this tissue, which is the palatine tonsil. It's a large aggregation of white blood cells that will be encapsulated in connective tissue and located here at the entrance into the body, because obviously food that we eat is going to have a lot of microbes in it, and it allows us to begin an immune response if we find that what we're eating is going to be able to cause an infection in this entryway. So we'll see that there's many tonsils associated with the entry point. All right, so we have here these very large palatine tonsils that are going to be sitting in between the plateauglossal and the platopharyngeal arches. Okay, so I have here the palatine tonsil is this immune structure that's going to be sitting between the arches. And again, these are just folds of the mucous membrane. They do have a little bit of smooth and skeletal muscle within them, and they'll function to help us also in swallowing. Okay, this is actually looking at the plateauglossal arches in the soft tissue, so we can see here photos. I would suggest actually looking in a mirror. You can open up your mouth and look in a mirror, and you can actually see these structures pretty easily. So if you look in your mouth, you can see here's the plateauglossal arch in the front, right? Here's the uvula. We'll talk about that in just a second. And here again, you're going to see the plateauglossal arch on this individual. And then here's the platopharyngeal arch back here. And here we see the platopharyngeal arch back here. And essentially, these are extensions off the soft palate and will mark the end of what is the oral cavity and beginning of what we call the pharynx. So if you kind of look back here, this is the back of the throat, what we call the pharynx. So if you were thinking you're a little tiny person here and you're walking across your tongue and you're walking this way, right? As soon as you pass these two archways, you're then going to fall down this very long tube opening, which is the beginning of what we call the pharynx. Okay, and again, we can see the tonsils here. These sort of enlarged areas of immune structures. Depending on the individual, these may be more or less obvious. There's a lot of variation from person to person. When there is actually an infection in the throat, these can be quite swollen. So here's the tonsil in this individual. And you can see a little bit of on this side, you can't really see it quite so much, but it's a little bit back there. And again, you have here the plateauglossal, and then behind the platopharyngeal arch. And again, here's the plateauglossal, and here's the platopharyngeal arch. Okay, and the uvula right in the center. We can see the pharynx back in here, the back of the pharynx, and then of course this is the tongue. All right, so this exit point that we talk about, so if you're this little person, you're walking past these arches, this archway is referred to as the fauces. So the fauces is essentially the exit of the oral cavity and the entrance into the pharynx. All right, so this is just a nice enlarged view. Again, a photo of someone's oral cavity and entrance into the pharynx. So again, here you can see this is the back of the tongue. Here we have the plateauglossal arch, the edge of it, the uvula. Here's again the plateauglossal arch. This is the tonsil, okay, on either side, tonsil. And then you can see a little bit of platopharyngeal arch right back there. At least on this side, I can see it. Okay, so we talked about teeth in lab, and we're not going to go into a lot of detail on teeth, but the teeth are an accessory structure to the oral cavity because obviously food doesn't travel through your teeth, but it does aid in the mechanical breakdown of food. So it helps to decrease the size and increase the surface area of what we're eating. And so it's a very important aspect of digestion. So teeth are beginning the mechanical breakdown of food, and again are an accessory structure to the digestive system. The next are the salivary glands. The salivary glands, there are actually 3 sets of salivary glands that are mirrored on each side of our head. And this image here is showing us those 3. The largest is the parotid gland. It sits right here on the lateral aspect of our face. We have the submandibular gland, which is going to sit right below the mandible. And then we have the sublingual gland that's going to sit underneath the tongue, right? And in fact, their naming tells you sublingual. Linguist is another term for tongue. So these are going to sit underneath the tongue, inside essentially the contours of the mandible. Submandibular is actually below the mandible, and we'll talk about this in just a second because you actually can feel that one pretty easily with just palpation. And then the parotid gland. On average, we actually produce a tremendous amount of secretions digestively in a day. On average, you might be producing between 7 and 8 liters total of digestion secretions per day as part of digestion. And the salivary glands begin that production of fluid as part of digestion. They make about 1 to 1.5 liters of fluid a day that goes into that GI tract. So when we look at the first of our digestive salivary glands, it's the parotid gland. The parotid gland is going to sit essentially just inferior to the zygomatic arch. It's going to sit right on this lateral edge of the ramus, okay, and just anterior to where the external auditory canal or meatus is. So there's where the ear is. So if you kind of palpate the back of your mandible, right where that flat part is, you can feel the angle. If you kind of touch that side there, so it's kind of under and in front of your ear, below your cheekbone, and on the side of your mandible, that's where your parotid gland is sitting. It is the single largest gland. If you actually looked at it in the cadaver, it kind of looks like it has these little tight lobations to it. I like to think, oh, it's going to sound bad, but it kind of looks like the surface of cauliflower. If you've ever seen cauliflower, kind of has really, really tight little lobes that are secreting through exocrine gland secretion, saliva. And the majority of the saliva is going to be water. And then in that water are going to be enzymes that function to begin the breakdown of our sugars or carbohydrates. So this is the first one. This is the parotid gland, and it's replicated on both sides. The secretions from this gland enter the oral cavity through the parotid duct, which you can see right here, parotid duct. And then these will go in to the oral cavity. And if you wanted to feel that gland, you can, or at least the entry of the parotid duct from the parotid gland. It comes in right around that second molar. If you're looking inside on the between the cheek and the molar on the inside, there's a little tiny bump that you might feel right there if you run your finger along the inside between your cheek and your teeth. And it's pretty far back, so you're going to have to feel all the way back by that second molar. So if you haven't had your wisdom teeth break through, it'll be your last tooth. All right. When we look at the next gland, this is going to be the submandibular glands. These glands are quite palpable, meaning you can feel them. If you take your hands and you put them right along the edge of your mandible, and you go all the way back to the back edge where you have the ramus and the angle of the mandible, feel underneath on either side of your throat, and you're going to feel these really big kind of mounds that sit there. Those mounds, a lot of people think they're lymph nodes, but those solid mounds that sit just underneath the mandible on either side, right where the ramus is and the angle of the mandible, those are your submandibular glands. Those are the most productive in the sense of producing saliva of the 3 glands. They're paired on either side. They have a nice, long, very visible opening submandibular duct that comes into the oral cavity. So here they're trying to show you the submandibular gland. It's actually much larger than what they have drawn here. But you have this submandibular duct that's going to travel forward underneath the tongue. And then right at the base of the mouth, anterior base of the mouth, where the tongue actually attaches to the floor of the oral cavity, if you lift up your tongue, put the tip of your tongue to the top of your hard palate, right where your teeth are, you're going to notice that the tongue has basically a separation. We call it the frenulum, called the lingual frenulum, that attaches essentially the tongue to the floor of the mouth. And on either side of it, if you look really carefully, you're going to see little tiny holes here and here. And those are going to be the openings to the submandibular ducts. And again, this guy produces a quite substantial amount of saliva. The parotid gland makes only about 25% of that total liter to a liter and a half of saliva, where the submandibular gland is going to produce about 70% of the saliva produced in a day. This is a little quick video that I'll show you where you'll actually see saliva coming out of the submandibular gland. A lot of you know this phenomenon as gleeking. So if you kind of take your tongue and you put it against the roof of your mouth, you kind of fold it backward and then close your mouth down on top of your tongue, that actually squeezes what is in the submandibular duct and can cause it to squirt out. And so that's what's going to happen here. See him putting his tongue up. You can see the saliva comes out in slow motion. So his tongue is going to go up. There you can see the saliva coming out, and those are the submandibular ducts. Those are the openings. So you see his lingual frenulum right in the center. There's that lingual frenulum, and you can see the two openings on either side. So that's secretions from the submandibular gland. Okay, so the last of our glands is called the sublingual gland, and this gland you can't really palpate very well. Actually, you can't palpate it at all. It sits on the inside of the mandible. So when you think about the mandible, remember it's a nice big U-shaped bone. It sits on the inside of that U on either side and underneath the tongue. It has about 20 little tiny openings that open up into the oral cavity. You can see them right here along the inside of the tongue on either side between the tongue and the teeth. So this guy is the least productive. It only makes about 5% of that total liter to a liter and a half. Right? So this here is the sublingual gland. And again, all three of these glands are going to be kind of these little tight lobations. So lobules like these are little lobations. The submandibular has slightly larger lobations, maybe because it's much more productive as gland. All right, so then we're going to look at the tongue. The tongue functions again as an accessory structure. It does a number of things. One, obviously, it provides a lot of sensory information. It allows us to taste what we're eating. That will also affect secretions and how much fluid we secrete. But it also physically moves food around. The surface of the tongue is very abrasive, has little papillae on it, which we'll talk about, that help us move substances around so that we can put our foods into the grinding surfaces of our teeth or squished against the hard palate. And then we're also going to see that it has a lot of recesses and crevices in the tongue that will help keep saliva on the tongue. That helps also in sensory, because it'll allow what we're eating to dissolve in the saliva that essentially is sitting on the tongue. So we'll talk a little bit more about that sensory part of this as well. So the majority of the tongue is skeletal muscle. In fact, it's one of the most powerful muscles in our entire body. Even though it's relatively small, it can produce a tremendous amount of pressure when it pushes. It's going to be covered with a mucous membrane. In fact, remember, the entire GI tract essentially is lined with a mucous membrane. But obviously, this one's very modified to provide the friction for moving, as well as the sensation or the sensory structures, which are going to be nervous tissue embedded within this mucous membrane. All right, so looking at the surface of the tongue, you can kind of stick your tongue out and look at it in the mirror. You'll notice it is not smooth like the palate of the mouth, so the hard palate and soft palate and uvula and platoglossal and platopharyngeal arches. Those are all smooth mucous membrane. The tongue doesn't have a smooth mucous membrane. It has papillae on it, so we're actually going to use that same term we used with the skin when we looked at the dermis. We had the dermal papillae. So papillae just means cone, and so the surface of the tongue has these really cool cone-like projections, and there's 3 different kinds that provide different functions for the tongue. So we have the filiform papillae, the fungiform papillae, and the circumvallate papillae. So again, when you look at the surface of the tongue, you'll notice that it's not smooth. It has all these little bumps all over it, and those are the ones we're going to look at right now. All right, so the first are the filiform papillae. So these guys are these little thread-like real thin little cone-like projections. This is a scanning electron micrograph of those guys, so you can kind of see what they look like. They're these kind of thin little cone-like projections. This is just showing you debris that's kind of caught in between those little filiform papillae. They're very numerous. In fact, they cover the majority of the tongue. And we estimate approximately 2/3 of the tongue is covered with these little filiform papillae. And their primary function is going to be to create friction. So when you're moving substances back and forth within the mouth, it creates a grabbing surface for the surface of the mouth, or sorry, for the surface of the tongue. So if you stick your tongue out, you'll notice the majority of it has these little tiny filiform papillae all over the surface. All right, the fungiform papillae, if you stick your tongue out, you'll notice every once in a while you have these little tiny bumps that are kind of in between all the filiform. They look like little tiny buttons. Oftentimes, when you're biting or chewing, these are the little ones that can sometimes get abraded by the edges of your teeth, or sometimes you might bite one as you're chewing. And then some people say, "Oh, I have an infected taste bud." Well, it's actually one of these little fungiform papillae. It's not technically a taste bud, but it actually contains taste buds, which we'll look at in just a second. So in this scanning electron micrograph, they're showing you all the little filiform papillae. These are the little thread-like ones that create the surface area, majority of the surface area. And then these are little button-like fungiform papillae. They're named because they kind of look to whoever was describing like little mushrooms. So it's fungus or fungiform because of their shape. They're cover the majority of the surface of the tongue. So when you look from the tip of the tongue all the way back, you're going to be able to see all of these little fungiform papillae. So they're going to cover essentially the front and all the lateral surfaces all the way back across the tongue. And again, they're going to contain taste buds, which are going to be the sensory structures along these inside edges where they have a recess. All right, and then last but not least are what we call the circumvallate papillae. And these are the largest, and they actually sit kind of in a big fat V on the back of the tongue. So if you stick your tongue way out, you're going to see this kind of V-like aggregation of big mounds of mucous membrane papillae. Usually have between 8 and 12 of them going back and forth in this kind of V-like shape across the what we call root of the tongue. And these are the circumvallate ones. They also are going to house taste structures. So we have taste structures or taste buds in our circumvallate papillae, as well as our tiny little fungiform papillae, which you're going to see across the whole surface, the front and the lateral sides surface of the tongue. All right, so this is actually a really great drawing showing us the circumvallate papillae. So this is a really large circumvallate papillae. Kind of see it there. You can see it has these really deep recesses on either side, and that's to collect saliva. And that will allow us to dissolve constituents which are in the foods we eat. And those will then be able, once they're dissolved, to diffuse and associate with these structures. And these are actually your taste buds. They line up along the inside edges of these big, deep recesses. And so those are actually the taste buds. And I'll show you those in another slide. So this is looking at actually a fungiform papillae right here. And this is one of those deep recesses. And we can see these little taste structures all along the inside edge. This is a magnified view of one of the aggregations of taste structures that sits along the deep recesses. So this is a fungiform papillae, and we can see these guys. These are the nervous tissue structures that are able to sense or taste constituents in what we're eating. They have a little taste pore right here. You kind of see one of them. And those taste pores are going to have diffusion of constituents that we're eating into them and associate with the neural tissue that sits inside this taste bud or taste structure. All right, so these clusters of sensory nerve cells lining the sides of the recesses of the papillae, those are going to be what we call our taste buds. All right, and then, actually, let me pause. Can I move this? Okay, and then the next thing is looking at the lingual frenulum, which I mentioned already. If we look at the lingual frenulum, you can see it right here. Oops, let me make sure I can. There you go. Here's the lingual frenulum. And the lingual frenulum is a really important structure as it holds essentially the base of the tongue down to the floor of the mouth. It's important in the sense of providing the ability of the tongue to move. It anchors it to the floor. Here you can see them using a clinical tool, actually a little scissor, and they're cutting the lingual frenulum. And that's because in some cases it can be a little bit too tight and it makes it difficult for the tongue to move. And so much of our speech comes from the movements of our tongue and where our tongue sits within our oral cavity. And sometimes, if you have an inability to say certain sounds or letters, well, one of the reasons for that might actually be a lingual frenulum. It's too tight. And then here, the S, they're just pointing out the submandibular gland duct openings. All right, so we're done with the oral cavity, and now we're going to move into the pharynx. So the oral cavity is actually going to stop right here, and we're going to move into what we call the pharynx. So oral cavity is going to end as we exit from essentially our fauces. So we can't quite see it, but this would be where the platyoglossal arch is. This would be the platopharyngeal arch right there. And then from this fauces, we enter into the pharynx. The pharynx basically is what we call a common space, or AKA the throat. The pharynx is going to be divided up into three major regions: the nasopharynx, the oropharynx, and the laryngopharynx. We mean commonplace because technically the pharynx can pass both ingested substances as well as inhaled substances. So, although it's not advisable, if you wanted, theoretically, you can push what is ingested up into the nasal cavity and kind of shoot it out the nose. Some people, for example, will say, "Oh, I can, drink milk, for example, and shoot out my nose," and that is possible. Obviously, you know that if you create mucus in your nose, a lot of times you can pull that into your mouth, and you can, of course, swallow that. And then, of course, things that we eat should actually move down through the esophagus, but sometimes can get travel where they're not supposed to go, which would be into the respiratory structures. But the pharynx is this common space, aka throat, for the passage of both air and ingested substances. So, boundaries of these different regions. Nasopharynx is basically the area of the pharynx that is above the soft palate. So I have here superior aspect. So if we look at the soft palate here, the soft palate and above, this is going to be the nasopharynx, right? If we look at the oropharynx, oral meaning oral cavity, This is moving between the soft palate. And if you remember in lab, we talked about the hyoid bone. There's the little hyoid bone right there, the hyoid bone. And we're looking at this area between the hyoid bone and the soft palate. Change my color here. There's a little hyoid bone right there. So between the soft palate and the hyoid bone is the oropharynx. And then between the hyoid bone and the beginning of what is esophagus. So this is the esophagus right here. And so if we're looking at the boundaries there, we say between the hyoid bone and the beginning of the esophagus. So this here is the laryngopharynx. And they call it laryngo because the structure that's right in front of it, that right there, that's the larynx, okay? Or what people call your voice box, okay? So we're looking again, we're gonna say our oropharynx is this area between or above the soft palate, okay? That's nasopharynx. So the nasopharynx is above the soft palate. The oropharynx between the soft palate and the hyoid bone. Hyoid bone is right here. And then the laryngopharynx is between the hyoid bone and the beginning of the esophagus. So this is our, oops, right there is laryngopharynx. All right, so this is just a nice view of the side of your textbook, looking at the different areas. This is a mid-sagittal section, of course, through the head. And we can kind of go back and look at all these great structures we've talked about already. So here's the hard palate, right? So that would be made up of the maxillary bone and the little palatine bone. We have the soft palate, which extends this way. And then we'll talk about the uvula in just a second. The uvula is an extension of the soft palate. We looked at, obviously, the dentition in lab. Here they're trying to show you the opening to the parotid duct. So again, this is on that inside edge of the cheek, right about that second molar. We can see the platoglossal and the platopharyngeal arches, right? As we exit the oral cavity, they're trying to show you here, this is the fossa, so this is the exit of the oral cavity, entrance into the pharynx. I can see the tongue here. They're not showing us the salivary glands because they're going to be lateral to the midline, so you're not going to see them from here. And then we should have a little bit of that little submandibular duct that comes in on the inside edge. Let's see, I can also see the hyoid bone right here, and that's a nice landmark. So it gives me a dividing point. So between the hyoid bone and the soft palate, this is my oropharynx. And then between the soft palate and above, this is the nasopharynx. And then from the hyoid bone to the beginning of the esophagus, this would be laryngopharynx. Okay, so just a little bit on swallowing, and this is where I'm going to talk a little bit about that uvula. Swallowing has a fancy name, and they call it deglutition. This process is really important to make sure that it occurs correctly so that we don't have food moving into the nasal cavity and we don't have food moving into the respiratory structure, so your breathing tube. So swallowing is conscious. We consciously control this. Obviously, we're going to have skeletal muscle invested into the pharynx and into the beginning portions of the esophagus. So when we swallow, that partially digested substance that we've now chewed and added saliva to, they call a bolus. So when you see this term bolus, it just means a partially digested mass of food that we're bringing into our bodies. The bolus is going to stimulate the uvula. So when we start to swallow, which is going to be initiated by skeletal muscle involved in the pharyngeal muscles, that bolus will touch the uvula and it contracts and it actually moves upward. You can kind of see that here. This also is because the pharyngeal muscles are going to be pulling, so that also helps. But we want this little uvula to go upwards because we want to make sure that we're closing off the opening to the nasopharynx. So food has a very difficult time passing and going upward. Okay? So we're going to have laryngeal muscles that contract are going to help close off that glottis. The glottis is the opening to the respiratory structures. So we'll look at that in just a second. But we're going to see that we use our uvula here to close off the nasopharynx, right? And then we're going to have some muscles associated with the larynx, which is this sort of cartilaginous structure here that will help make sure that we close off the opening to our respiratory structures. And that opening is called the glottis, okay? So this is the pharyngeal phase of deglutition. So we look here, we can see the uvula going up, the bolus is getting pushed backwards. The esophagus actually sits behind the respiratory structures. So you can see how the tongue goes up, it pushes on the hard and soft palate that helps to force this bolus posteriorly. The uvula moves upward, and we can see this bolus is going to start to travel posteriorly past our laryngeal structures. This is our larynx right here again. All right, so this is a quick little video on swallowing, and then we'll talk a little bit more about the larynx and some of the structures that are important there.
Swallowing occurs in two stages, the oropharyngeal and esophageal stages. At the start of a swallow, a food bolus is voluntarily pressed by the tongue up against the roof of the mouth and backwards towards the pharynx. In response to activation of pharyngeal pressure receptors, the swallowing center in the medulla initiates reflexes that prevent food entry into respiratory passageways. The uvula contracts, which blocks the nasal passages from the pharynx. The laryngeal muscles contract, closing the glottis at the top of the trachea by tightly aligning the vocal folds. The epiglottis swings down upon the closed glottis. With all airways blocked off, respiration is temporarily inhibited. As the upper esophageal sphincter relaxes, pharyngeal contractions drive the bolus into the esophagus. The oropharyngeal stage is done and breathing resumes. During the esophageal stage, a primary wave of peristalsis initiated by the swallowing center pushes the bolus through the esophagus. As the bolus travels through the esophagus, the lower esophageal sphincter relaxes, allowing the food to enter the stomach. If the bolus is sticky and adheres to the esophagus, secondary peristaltic waves triggered by the intrinsic plexus at the point of distension completely clear the esophageal lumen to finish the swallow.
Okay, so that's a really great video kind of showing us what's going on. Again, when we swallow, our tongue is going to go up. We're going to push that tongue against the roof of the mouth or the hard and soft palate. We're going to see that creates some pressure that's going to stimulate the uvula to contract and move posteriorly and superiorly to block off the nasal cavity and nasopharynx. We're going to see that the larynx, which is this entry point into the respiratory structures, is going to need to close off so we don't have food moving down into our air pathways or respiratory pathways. And then that bolus gets pushed posteriorly into the esophagus. So we're going to talk a little bit more about the larynx as we move forward, especially with our respiratory segment. And we'll talk a little bit more about this little guy. This is the epiglottis. It's actually a little flap of cartilage. And so whenever we swallow, you're going to, if you just, take your hand and put it on your throat, when you swallow, you're going to realize that your larynx moves upward, right? Your larynx and your trachea. So the larynx is that nice cartilaginous voice box, or your Adam's apple. That moves upward. We're going to use our laryngeal muscles inside to close off the opening here, which is called the glottis. And as the larynx moves upward, this epiglottis, epi means above, glottis is this opening, is going to fold backwards and close that off to make sure that food doesn't enter again, those respiratory structures. In the video, they mentioned that during the moment that you swallow that bolus through the pharynx, you actually have to stop breathing for that to happen. Sometimes when you're talking, which requires air moving, and eating at the same time, you can get food moving down the wrong tube. And that's because this opening doesn't get to fully close if we're trying to talk while we're eating. And sometimes that food, especially if it's a liquid, can move into that anterior respiratory pathway. This is looking at a photo inside the mouth, and you can kind of view the structures we've already talked about. So again, you have those platoglossal and platopharyngeal arches back here. So there's the platoglossal, and then back there, the platopharyngeal arch. Sorry, there's a platopharyngeal arch, platoglossal arch. You can see the tonsils on either side. There's the little uvula. And this little guy poking up from behind, kind of looks really white, is actually the epiglottis. This is that cartilaginous flap that's actually going to fold backwards when a bolus of food rides over it and the larynx gets pulled up. All right, and I'll show you a picture of that. So what we're going to find is that the movement of the bolus is going to occur because we have contractions of these pharyngeal muscles, so muscles associated with the pharynx. They're going to pull the hyoid bone upwards, raising the larynx or your voice box. Like I said, if you put your hand over your voice box or larynx and swallow, you feel it gets pulled upward. When it does get pulled upward, so this is prior to swallowing. So this is the little epiglottis that sits open here above. So now we can have air moving in and out through the respiratory structures. But while we swallow, here you can see the uvula is pushed upwards, closing off the nasopharynx. The larynx has been pulled up, and we're going to see that this epiglottis here is going to fold backwards. So food doesn't have an option of traveling anteriorly into the respiratory structures. So this little elastic cartilage plate, so it's made of elastic cartilage, so it's very sort of springable. It can fold it back and forth, it regains its shape. It will close the opening to the respiratory structures, and I call that opening the glottis. And this little elastic cartilage plate that sits over the opening, we call the epiglottis. All right, so this is a little swallowing video that'll show that.
Nice open nose then. Wow.
So there's the epiglottis, you can see it. Oops. What should I? I'll go back. There you go. I guess I can't point it out. So they're taking a camera and putting it down through the nose, and then you're looking down in the pharynx. And there's the little epiglottis. This is the larynx. So those are the vocal structures there. And this is the esophagus back here. So now they're in the esophagus. That's where food would travel. Coming back up. So there's the esophagus again. You're now in the esophagus. Notice it's kind of a closed tube. There you go.
Such a good normal if I can get Nick to do that like that.
I'm pulling it back up. And this is the respiratory structure. So those are your vocal structures inside of here. And there's right there are the vocal cords. Now you can see them there, the little white guys. Those are vocal cords. And there's the epiglottis. So if we look down, that's the entrance to the trachea or your windpipe. And these are the laryngeal muscles that are going to close it off.
There we go. That's so cool. Oh, that's a great way to check.
There you go. Yeah, so that again, that's the larynx. So these are the vocal cords right there and there. That opening is the opening to the larynx. There's the opening. And if you look inside, that's the trachea. And what you're showing are the laryngeal muscles closing that glottis right there. And that's the epiglottis. Yeah, and they're having her swallow.
And how about a few gulps, like successive?
Every time she swallows, her larynx is getting pulled up. You can see the laryngeal muscles closing the glottis, and you can see the epiglottis kind of folds backwards. Okay, so this is a still image of that. It's actually flipped. So in this image, here's the epiglottis. All this kind of moundy stuff here, these little bumps, this is actually the lingual tonsil. So it's another set of immune structures. So you have the palatine tonsil, and then you have what we call the lingual tonsil. We actually have a lot of tonsil associated with the oral cavity. And again, this white piece here, that's the epiglottis. This is the opening to the respiratory structure. So that's the glottis. These are the vocal cords right here. This is the smooth mucous membrane that overlays some laryngeal muscle that's going to help to close this off. And then if I could put my pointer down here, that would be where the esophagus is. The esophagus is going to sit posteriorly. So this is the back of the throat or the back of the oral pharynx. And then this is the tongue. So this is anterior. Okay, so now as we move out of the pharynx, we're going to be moving down toward the stomach. And the way we get there is through the esophagus. That little video had a piece of the esophagus, or what happens there as it moves from the pharynx to the stomach. The esophagus is really just transport. It's moving what we're eating through our thoracic cavity. We really want it to move from our mouth and pharynx really quickly through the thoracic cavity and down into the abdominal cavity where the stomach's located. So the esophagus is this muscular tube that has some skeletal muscle at the beginning part of it. Most of it is going to be smooth muscle. It's about 1 foot in length, and it can propel what we're eating through it very, very quickly in about 1 to 5 seconds, depending on the viscosity. So it's going to use those alternating muscle contractions to move what we're eating through that thoracic cavity. The esophagus is going to sit posteriorly. So it's going to sit way back in the thoracic cavity, kind of against the vertebrae. All right, so I have here carries food from the mouth to the stomach, propels that bolus. It's still called a bolus at this point. It's partially digested, meaning we've chewed it, and we've added saliva, and we've added the enzyme amylase, which actually digests carbohydrates. It's going to push food in about 1 to 5 seconds through it. It's going to be made up of a nice stratified squamous epithelium that's going to secrete a lot of mucus to help slide substances down through it. So it's going to secrete mucus that'll help to lubricate and also moisten that bolus. So orientation, this is a nice view of that. So here you can see in the neck, it's going to sit behind the respiratory structure. So there's our windpipe or our trachea. As we go into the thoracic cavity, it's going to take a very posterior movement behind the lungs and the heart. It's going to go through the diaphragm. So this is where the diaphragm would be located, and it goes into the abdominal cavity and then essentially joins the stomach. So I have here just arrangement of it. In the cervical area, it's going to be behind your trachea or windpipe. In the thoracic area, it's actually going to sit behind the heart and lungs in what we refer to as that mediastinum. So it's not actually in the body cavity. It's not surrounded by a serous membrane. So this actually part of the GI tract, just as a side note, isn't covered with serosa, because the serosa or serous membrane is covering structures that are in body cavities. It's actually covered with what we call the conjunctiva. So it's this thick connective tissue that kind of helps support it within that space. And then as it goes into the abdominal pelvic cavity, it's going to go right through the diaphragm. There's going to be an esophageal hiatus, which is actually an opening in the diaphragm, which will allow the esophagus to travel through it. Okay, and then these are just pictures looking at the esophagus here traveling through the thoracic cavity. Here we can see the diaphragm, so this would be the esophageal hiatus. And then the esophagus travels through and then joins into what we call the stomach. All right, so last little piece, this is looking actually a little section of the diaphragm. So this is diaphragm right here on either side. This is the smooth muscle of the esophagus, right, traveling this way, that's smooth muscle. The inside would be the mucous membrane. We'd have the submucosa. This is muscular externa. And then we have at this point, it's actually called the conjunctiva. And then as we enter into the abdominal pelvic cavity, then we're going to have a serosa. This thick area of muscle of the muscularis externa at this point is actually referred to as the lower esophageal sphincter. It's going to be a ring of smooth muscle. So we have that intercircular layer is really large. And this will function to regulate the passage of substances between the esophagus and the stomach. And what it primarily does is it relaxes when a bolus of food sort of moves from the esophagus into the stomach. So it's primarily closed off. So it's going to allow the movement of esophageal substances into the stomach, and it prevents the reflux. So we don't want substances from the stomach to move back. So this is always going to be closed off, and we're going to see that it prevents substances from moving from the stomach backwards. So I have here prevents reflux of stomach substances or gastric substances. They call them gastric juices. One very common clinical correlation that we can recognize is what's called GERD. You ever heard the term GERD? That stands for gastroesophageal reflux disorder. This is where the lower esophageal sphincter doesn't adequately close and allows the gastric substances to reflux into the esophagus, which isn't effectively protected from those gastric substances. One of the primary gastric substances is actually hydrochloric acid. Gastric substances can have a pH of about 1 to 2, which is extremely acidic, and that can actually burn the inside layers of the esophagus and cause a lot of pain and irritation, which we associate with the heart. And so oftentimes we call it heartburn, but it's actually really the esophagus. The esophagus at this point sits right behind the heart, and so often it's difficult to tell where that pain is coming from. And someone might think it's coming from their heart, but it's really actually coming from the esophagus. This is looking at a photo of someone who has GERD, and you can see the irritation along the inside of the esophagus here, the swelling and inflammation. That's coming from the irritation of all that acid. It actually can cause the esophagus to create ulcers and eventually rupture, which is quite dangerous if it happens. Lots of things you can do to prevent it. Obviously, you can modify your diet. There are many things that stimulate secretion of acids like coffee and spicy foods, so you can reduce that. You can make sure that you eat smaller amounts of meals rather than larger amounts. The more full the stomach is, the more likely it is to reflux. And then also you can take some over-the-counter medications that help to neutralize some of that acid. Some of them help to coat the inside of the esophagus. And if it's really bad, you can actually take prescription medications that prevent the production of acid by the stomach. All right. So looking at the histology of the esophagus, it's actually very easy to identify esophagus because you're going to see the mucous membrane is going to be modified into a stratified squamous epithelium so that it functions for the passage of substances. We're also going to see in the submucosa lots and lots and lots of mucus glands. Mucus glands kind of look really icy. They're cuboidal glands, but they're kind of clear and glassy or icy in appearance. So in this photo here, these are all mucus glands. They have a little G there that stands for gland. So these are all mucus glands. You see a huge aggregation of them in the submucosa. This is the muscularis mucosa right here. So this is the lamina propria of the mucosa, and then this is the stratified squamous epithelium of the mucosa. So we have the stratified squamous epithelium, we have the underlying lamina propria, we have the muscularis mucosa, and then in the submucosa we see just lots and lots and lots of mucus glands. All right, now we're in the stomach. The stomach is this J-shaped organ. The stomach functions to initiate the digestion of protein. It also helps to churn and mechanically digest substances that have traveled into it from the mouth. And then it also is a temporary storage structure. It can store foods for several hours, so on average from 2 and 4 hours. So if you're eating a large meal, and we tend to be intermittent feeders, we aren't grazers, so we tend to eat breakfast, lunch, and dinner. So we need to have a place for all that food to sit while we're getting ready to slowly digest it. So that's why we have it as a temporary storage. It's going to be anatomically structured to stretch. So we're going to see some modifications so that it actually can store up to a liter of substances within the stomach comfortably without having too much distension occurring. So on average, we're going to secrete about 1.5 liters of substances into the stomach throughout the day. It typically can hold comfortably to about 1 liter at a single period of time of fluids. All right, so here you can see the stomach. Again, it's this J-shaped structure. It sits on the left side of the abdominal pelvic cavity. So here we see this is the esophagus. It's going to come through this central area of the diaphragm, and then it's going to move off to the left. You can see that where the esophagus comes in, it comes in kind of on this medial edge of the stomach. The stomach is going to have this kind of enlarged superior lateral sort of appearance here. So you have this kind of large area here we call the fundus. And then it has the body, which is the main sort of storage and churning chamber. And then it's going to end in this area here called the pylorus, okay, before we move into small intestine. The area right around the esophagus is referred to as the cardia. Okay, so that's what this is here. These are drawings showing us the major regions. Again, the stomach is going to sit on the left side of our abdominal pelvic cavity, just hunkered in right underneath the diaphragm. Again, we're going to see the esophagus comes through the diaphragm and comes into the stomach on this medial edge rather than the top of it. So this kind of left superior area above where the esophagus comes in is the fundus. The major storage and churning structure is the body. And then this area here where we're exiting the stomach and entering the small intestines is called the pylorus. It's going to be really thick muscle there. And then this area right around where the esophagus comes in, we call it cardia. All right, so the cardia is the superior region surrounding the opening of the esophageal sphincter. So this is a really nice drawing here. Here's the esophagus coming in. They're showing you the cardia is this area right around where the esophagus comes in. And this fundus is going to be the superior lateral area just to the left of the cardia. As food comes in, it's going to travel into the fundus first, and then it's going to sift down into the body. Okay. All right, the body is the main storage and churning chamber. So as food comes in, it's going to be sort of directed into the fundus, and from the fundus down into the body, and then eventually into the pylorus. The pylorus is going to connect directly to the small intestine. The pylorus is the exit point of the stomach. It's going to have a really thick muscular sphincter right here, referred to as the pyloric sphincter, that will be regulating the exit of what is in the stomach into the small intestines. All right, so this is looking at the pyloric sphincter. We look at the pyloric sphincter, it is really thick muscle. If we had the opportunity in lab to feel it, it's actually pretty easy to tell where the pylorus is because the majority of the stomach kind of lays flat when there's nothing in it. And as you get to the pylorus, it's a really, really thick muscle area, almost the thickness of the medius part of your palm. So this area, we're going to see that there's this sphincter. So this is looking at the sagittal section through the sphincter. So here's the small orifice that foods would travel from the stomach into the small intestine. They estimate you have about a teaspoon of fluids that can exit through here at a time. So it's a very, very slow movement of what we have in the stomach into the small intestine. This is an endoscope photo. So they're looking from the stomach view through the pyloric sphincter orifice, and through that spacer, that would be the small intestine. All right, looking at the histology of the stomach, there are many really amazing features about it. The first is that it has some really unique macroscopic folding. I mentioned this really briefly when we talked about mucous membranes at the beginning of our digestive lecturing. But you see these really nice longitudinal foldings that go down the length of the stomach. They kind of go back and forth, but they're kind of like this corrugated slide down this inside edge of the stomach. These are called rugae. And these rugae will allow for the stomach to distend. We want to stretch it without tearing it. And so the mucous membrane is just kind of heavily folded into these rugae. So if the stomach is stretching, we'll be able to stretch those rugae out. So if you were to look at a stomach that was empty, the rugae would be really obvious and nicely folded. And if you looked at a stomach that had food in it that was really heavily distended by the weight of that food, these rugae would kind of flatten out and they'd be less obvious. So these are macroscopic folds in the mucosa. So this is an endoscope photo of rugae. Obviously, this is an empty stomach, so you can see these really thick longitudinal folds. So just like an accordion, if this stomach was full, these would then stretch out without obviously tearing. The mucous membrane we're going to see here has simple columnar epithelium, and so we don't want to tear those cells apart. So we're going to just kind of fold that membrane up into these really big corrugations. Again, when we look at the stomach, when it tends to be full, it's about 1 liter in content. And when it's empty, it's about 60, 70 mils of fluid. So again, we're going to look at this mucosa. These rugae are going to allow for the stomach to extend and expand. And then also helps to segregate digestion. So, when you eat something, it actually moves through the stomach in, I should say, the order that it was ingested. And the rugae help to kind of direct food from the fundus to the body to the pylorus. So if you were sick and you were throwing up a meal, it would actually exit in the same reverse order that you swallowed it. All right, and then this is looking at a histological image of the stomach. And again, the stomach is really easy to identify histologically because you're going to see these really big folds of the mucous membrane. Notice that the muscularis externa is smooth and round. So this would be a nice, smooth, round surface, right? And then inside is where it's corrugated and folded. And that's because muscle can stretch. So we can stretch this muscle easily without tearing it. And then the mucous membrane, we can expand. We can basically stretch out the folds there, and we get quite a large area of internal volume when that happens. So here, just a reminder, this is the mucosa. I have a little bit of lamina propria right there. There's my little muscularis mucosa. And this is all submucosa. And then there's my muscularis externa. So these big folds here, those are rugae. All right, so this is a quick video on traveling through the GI tract. You can see we're going through the esophagus at this point. This is an animation, so this isn't actually real. So they're animating what you would see if you were moving through, and they're showing you peristalsis right now. So that's the lower esophageal sphincter, and now we're moving into the stomach, and they're trying to show you the rugae of the stomach. Kind of looking up and down throughout the stomach. So there's supposedly food coming in, and there's another peristaltic wave. Let's see it moving down through the rugae. And then we're moving down, looking into the pylorus. So there's a pyloric sphincter. And if we went out through that pyloric sphincter, now we're in the small intestines. So we'll look at that next segment of the small intestine. All right, so histologically, the stomach is really unique. Again, we have the macroscopic folding that we call a rugae. And now we're going to focus specifically on the histology of the mucosa. So if we look at the mucosa is highly secretory. So we're going to make lots and lots of secretions. Again, you have about 1.5 liters, sometimes upwards to 2 liters of fluid secreted by the mucosa of the stomach. And what we're looking at here is a nice view of that mucosa. So when you look at it, you're going to notice if you were to walk across the surface, as you're walking, you're going to see these big kind of sinkholes here. We call those gastric pits. So the surface, inside surface of the stomach mucosa, you can see it's kind of flat here. And then we get to these big pits or openings. It's kind of like a big sinkhole. And at the base of these sinkholes are the gastric glands. And this is where we're going to be making protein digesting enzymes and then acid secreting cells. All right, so the mucosa is a very huge, large exocrine secreting structure. So we call it a secretory sheet. And what we're looking at here, if you kind of walk across the surface of the inside of the stomach, obviously aside from the rugae, tends to be relatively flat with these big crevices going down or sinkholes. Those are the gastric pits. And then on the edges of the gastric pits, these are all mucus glands. So these are kind of those little glassy glands that we see here. Those are mucus glands. And the farther we go down, that's where we're going to get down into these glands. These are where the gastric glands are. Those are going to be making your enzymes and your acids. So this is a nice simple columnar epithelium. You can see the nuclei of the cells, and these are the nuclei. You can see the cells have quite a tall or high surface to them, so they're columnar. This is another view. We're walking across the surface. Here's one of those big sinkholes. This is called a gastric pit. It's going to be lined with mucus glands, and that's going to help protect the stomach epithelium from the acid. So mucus is a really nice protective substances that coats the inside of the stomach that prevents the acid from degrading the cells. So we have, again, the gastric pit, which is kind of the sinkhole, and then lining the pit here at the surface of the sinkhole and the beginning portion of it are going to be mucus glands. And as we go further down, this is where we're going to get the acid secreting cells and then the enzyme secreting cells. All right, so first of all, we have our gastric pits. These are going to be shallow depressions down into the connective tissue. So kind of like you might see with a hair follicle, same kind of structuring, except in this case, it's secretory. So this is one of the pits. Again, it's a sinkhole. These are mucus glands here. They're going to make lots and lots of mucus to help coat the inside of the stomach with this nice protective mucus. And as we go down, we're going to see down in here, as we go further down, this is where we're going to see the acids and enzymes of the gastric glands are going to take place. So I have here gastric pits are these depressions in the lamina propria that contain mucus. The function is going to be protection against those acids and enzymes. Because these guys are constantly exposed to acids and enzymes, we're going to see, even though they do make mucus to help prevent their degradation, they're going to have a very fast mitotic division rate. So they're going to turn over every few days. All right, so these are looking at scanning electron micrographs. So these are the gastric pits. So if you were to fall down into one of these pits, there'd just be a ton of acid and enzyme kind of welling up from underneath. This is a histological image of the mucous membrane of the stomach. And here we can see these are all mucus gland cells. GP stands for gastric pit. So you kind of see this would be the pit here. These would be secreting lots and lots of mucus. And as we go down further, the gland's going to start to separate into all these little diversions, so side branchings. And that's where the gastric glands are. All right, so this is just another image of that. So again, here we're looking at the mucosa. So up here, these are the gastric pits, and then they extend down into these gastric glands that are surrounded by the connective tissue of the lamina propria. So again, here's one of those gastric pits. These are mucus secreting cells, and as you get further down, these are our acid and enzyme secreting cells. All right, so gastric glands are going to sit basically as continuations from the pits. So the pits are going to be the entry point, and then you're going to see it kind of branches into all these multiple side routes, which go down into the enzyme and acid producing glandular tissue. So these are extensions of the gastric pits down into the lamina propria. You kind of see here this gland, you can see it branching on either side here. This one, you can see one of the branches. And in red and in blue, these are the acid and enzyme secreting cells. In purple, we're going to see we actually have some endocrine cells, and those will be secreting into blood vessels. All right, so these are the three types of cells. The first two are exocrine, and the last one's endocrine. So the chief and parietal cells are the actual gastric juice kind of secreting cells. They make this gastric secretion. This is going to be that approximately 1.5 to 2 liters a day. So you're going to see what we call chief cells. These are making the protein digesting enzyme, which is called pepsinogen, or pepsin when it's active. Exocrine meaning that it's secreting into a space. So here, this is the mucus secreting cells up in here. This would be the pit. And then we go further down, this is the gland. And so they're trying to show you the acid and enzyme secreting cells. So you have the chief cells being the protein digesting cells, and then you have the parietal cells being the acid secreting cells. Parietal cells actually make hydrochloric acid. This is going to help in digestion, also helps in sort of breaking down any microbes that might be ingested as part of what you're eating. So it does have sort of an immune function there as well, but aids in the chemical breakdown of what we're eating. And then the enteroendocrine cells, entero meaning basically the part of the intestines, endocrine cells. There are 7 different hormones, and we're not going to go into all of them, but one of the major ones is gastrin, that functions to help regulate gastric secretions that are stimulated by stretch and distension of the stomach. So those are secreted what we call G cells, and these help stimulate, again, secretion from the chief and parietal cells. So this is a really nice view of the stomach. And again, we'll still have rugae, so the whole thing gets folded, but the surface is very flat relative. And then you have these pits going down into the lamina propria. So these are the gastric pits. They're all going to be lined with mucus glands. You kind of see that glassiness at the surface. And then as we go further down, obviously there are extensions, but we most often are not going to see it go completely from the pit directly into the gland, because the glands are going to be branching off of them kind of laterally. So all below here, this is all of the glands that are making the acids and enzymes. So that's why I say the gastric glands. They're going to be connected to the pits. So all of this is the mucous membrane. Remember that the bottom of the mucous membrane is marked by this nice muscularis mucosa, and then we have the submucosa below that. All right, so gastric juice essentially is the acids and enzymes and mucus that get made by these gastric gland cells. Again, it's about 1.5 to 2 liters a day. And the fluid now that is in the stomach, we refer to no longer as a bolus, but actually chyme. And chyme is this acid sort of laden, partially digested foods that sit in our stomach. All right, and then just a little bit on the musculature before we're done. The GI tract normally has 2 layers in the muscularis externa, but in the stomach we have 3. So there's going to be an inner circular, and then an outer longitudinal, and between the inner circular and the outer longitudinal, which you see down the entire GI tract, we're going to sandwich a middle circular. And in this drawing here, they're trying to show you the esophagus up here that has the inner circular and the outer longitudinal, so just the 2 layers. But in the stomach, you're going to see that we have an outer longitudinal, we're going to have an inner circular, and then, middle circular, and an inner oblique. So we have the 3 layers of muscle there. All right, so again, we're looking at the longitudinal muscle, the circular muscle, and then the oblique muscle. All right, and then over here, this is just another view of the mucosa. So again, we have the mucosa with the muscularis mucosa being the boundary, the lamina propria, and all these gastric glands that extend into the gastric pit that then opens into the lumen of the stomach, okay? All right, and the last thing to do is look at a little bit of gastric regulation, and this is the last piece.
Regulation of stomach secretion is divided into 3 phases: cephalic, gastric, and intestinal. In the cephalic phase, the taste or smell of food, tactile sensation of food in the mouth, or thought of food sends nervous impulses to the medulla oblongata. These impulses cause parasympathetic neurons via the vagus nerves to stimulate secretion of hydrochloric acid and pepsin in the stomach. The parasympathetic stimulation also results in secretion of gastrin from the lower part of the stomach. This hormone travels through the bloodstream and further stimulates hydrochloric acid and pepsin secretion in the upper and middle parts of the stomach. In the gastric phase of gastric secretion, food has entered and distended the stomach. This distension activates a parasympathetic reflex via the medulla oblongata and also has a direct stimulatory effect on the gastric glands. The result is continued secretion of hydrochloric acid and pepsin. In the intestinal phase of gastric secretion, chyme has entered the duodenum, so gastric secretion is no longer needed. When the chyme contains lipids from the digestion of fats or contains enough hydrochloric acid to bring its pH below 2, gastric secretion is inhibited. The lipids and hydrogen ions inhibit gastric secretion by 3 simultaneous actions. First, they cause impulses to go to the medulla oblongata to decrease parasympathetic stimulation of the gastric glands. Secondly, they set up local reflexes via neurons in the wall of the gut that decrease gastric secretion. Thirdly, they cause the release of 3 local hormones which travel via the circulation to the gastric glands and inhibit their secretion.